Hey everybody, it's Erik, co-founder, partner of Village Global, a network-driven venture firm. And this is Venture Stories, a podcast covering topics relating to tech and business with world-leading experts. Hey everybody, welcome to another episode of Venture Stories. I'm here today joined by a very special guest, Mark Goldenson, Village Global network leader, founder of VentureKit, previous founder of Breakthrough. Mark, welcome to the podcast.
Thanks for having me.
We're here today to talk about mental health startups, building digital health startups, and building companies broadly. Mark, why don't you give a brief background of your experience building a company in the mental health space?
Sure. It started when I came out to the Bay Area for college to go to Stanford. And strangely, it started with Star Trek. When I was in high school, I loved Star Trek Next Generation and loved the idea of the holodeck. And a friend of me said, you know, the holodeck actually exists. And I said, what are you talking about? And he said, well, there's this thing called lucid dreaming where you can guide your dream content. You can sometimes control it. You have full sensation and perception, but no physical or social constraints. I thought, this sounds amazing. I don't know if I believe it. He gave me this book called Exploring the World of Lucid Dreaming by Dr. Stephen Berge. And I read about it, tried some of the techniques, and then started to have lucid dreams. And I was already interested in psychology and neuroscience. So I thought, this is amazing. And when I thought about where I wanted to go to college, I thought, well, I'd actually like to help bring this to the world and understand why more people don't do this. And I think the main answer was it was still pretty challenging for a lot of people. So I thought, okay, I'm going to go to Stanford, and which is where Dr. Stephen Berge was. I got in, came to the psych department and did 4 years of research on the neuroscience of lucid dreaming using simultaneous EEG, fMRI to study what happens in the brain right before and during a lucid dream. And so what I learned from that is I think I continue to be excited about science and research, but I am happier when I'm working in a team and building product. I did a company during the dot-com boom that was trying to bring small businesses online, and worked at PayPal as a product manager, started a online game show network called Play Cafe. I was trying to basically do HQ trivia in 2007, which was challenging because the iPhone had just come out and this was like the crappy version that didn't have great internet access. And then from that experience with live video, because we had live actors just like HQ, came the idea for Breakthrough. How can I apply that live video to therapy? I think a theme here was an interest in connection, in mental health, in community, and in the last two companies about how to apply live video.
Cool. So yeah, let's get into what was Breakthrough and how did the idea evolve over time? How did you sort of navigate the idea maze that is where to build a company in mental health?
Right. Well, so it started with how can we apply live video because of this experience from Play Cafe. And I looked around and I had several experiences in the study of psychology. I found therapy personally useful. I was a counselor on a teen lifeline and in a program at the VA when I was in college. And so I was familiar with what I would consider four major problems in the mental health care system. The first is high cost. It's over $200 billion spent on mental health in the United States on mental health and substance abuse. And then at individual level, this is over about $1,000 per course of treatment. If you don't have insurance, it includes medications, travel, finding a sitter if you have someone at home, leaving work. The difficulty of accessing care. So over 90 million Americans live in areas designated as having a shortage of mental health providers. So I think it's over 75% of people in small towns have access to zero psychiatrists. And these are the providers that people don't know that prescribe medication. And so if you have ADHD, PTSD, depression, anxiety, and you could benefit from medication, what do? Well, the answer is people tend to self-medicate with drugs. They go to the ER and try and get Prozac, or they don't get care and they get worse. And we know this from the data. So access is a problem. A third issue is stigma. It's getting better in the United States, but still worse than in a lot of other countries where therapy and talking about mental health is more accepted. And then the fourth is provider fit, which I think is less appreciated, but when you look at the literature, what drives positive outcomes in mental health treatment, what I read is that the number one driver is therapeutic alliance, which is a fancy way of saying your connection with your provider. How much do you trust them? Do you like them? Do you think they're competent? And are you going to open up about what's going on so that you can get better care? So what fascinated me was that these four issues of cost, access, stigma, and provider fit can all be significantly improved by the internet. And that's what Breakthrough tried to do, is to deliver that along with the other major insight I had from the early research was the importance of getting reimbursement.
Right. And so what did you learn during that process?
So it was about a 3 to 4 month research process with patients, providers, insurers. I already knew that the product could be built. There's no black magic there. It feels like black magic sometimes to the payers, like web forms are amazing, but for us, we knew it was doable. So the number one about reimbursement. So 90% of mental health care spending is funded by a public payer like Medicare and Medicaid or a private payer like Blue Shield and Aetna. And so most companies that came before Breakthrough understandably wanted to go for a self-pay market. It's a lot simpler. It's just a two-sided marketplace, which is hard enough, right? Patients and providers. And I'll use provider to mean counselor, therapist, psychologist, psychiatrist, includes all those. And the problem is for consumers, they now have a choice between paying only their copay, which could be $25, $15, $0 to see some provider in person, or pay $100 to $200 or more online, and a much smaller pool of providers who are available for online care. And that cost differential is high. So really the big opportunity was making it cost equivalent. And then you can have the benefits of broader supply of providers, reduce stigma because you can get care wherever you are, and much deeper information about each provider on which to choose one. So a third of our network at Breakthrough had video introductions. And I love these because we bring in our therapist, we'd batch them in a nice office we set up for them. We would ask them an hour's worth of questions about what are their strengths, their weaknesses, what conditions they focus on, what techniques they focus on, and narrate that down, edit that down to a 2 to 3 minute video that consumers could then watch. Because going back to therapeutic alliance, you want that provider who really gets you. It's funny how much of a sense you can get that from just watching a 2 to 3 minute video. Whenever we had a new batch of videos, we would all sit around our conference table, watch them, and sometimes we talk about, would we see this therapist? And it was great. It was good to me that some people would say, no, that person's too touchy-feely, they're too analytical, they're too young, and so on. And it's maybe an unsavory comparison, but it's like a dating site where you want lots of different diversity to match the diversity of the consumer population.
Yeah. So let's say, Mark, that you were running a mental health fund solely for, and I know you're a health investor, but also generalist investor. But let's say you were just focused on mental health. First off, how would you sort of market map the types of companies that are potentially venture backable within the mental health space? Like what are the different types of companies that are the subsectors where there's opportunity?
Right. So you can segment in a few ways. Clearly there's telemedicine, telehealth, of which Breakthrough was an example. There are what are called digital therapeutics. So these are programs that may or may not involve a telehealth program. So if people are familiar with Omada Health is doing this in diabetes prevention, which has multiple components, and we could talk more about. I think that's an exciting area where you're combining metric tracking tech, human person, content, and a community. So I think that's exciting. Third is I think there are the AI chatbots. They're trying to do CBT, but I'm skeptical on there. We could talk more about why. Companies that are trying to improve biometrics for mental health, which I think is long-term exciting. So right now we don't have good measures of stress, at least in a consumer device. We don't have good measures of mood. There are some in the literature, but we really haven't, to my knowledge, miniaturized them to the point that you can get a mood ring like from Fitbit. That's good. But I think there are companies on the horizon of doing that. Question there is, what's the business model? Are consumers going to pay for it? Maybe if it's in the $100 range, because the real-time feedback of, hey, Erik, you're stressed right now and you may not have known that. It's a good time to take a deep breath or take a break. And then as long as you compare that with mood improvement metrics like assessments to show people that there's a benefit. This is actually, I think, a gap that some mental health companies miss, that people can be getting better but not know it because they're not tracking. Because mood is so abstract. At least could feel that way sometimes. We need the extremes in order to realize, oh yeah, I'm really happy or I'm really sad.
Right. And so let's analyze each individual subspace and talk about potentially big companies in the space or opportunity in the space. So telemedicine companies?
This is where I have scar tissue, right? With Breakthrough, because we were the largest online therapy service. We started in 2009. We sold the company in 2014. We had multiple acquisition offers. We had over 1,000 providers in our network. We had signed over 30 insurers. We covered over 10 million people. But the utilization, I think a dirty secret in telemedicine is the utilization is much lower than the promise. I believe telemedicine will eventually be the first line of defense in a lot of specialties, including mental health. Like the three big pioneers in telemedicine, when you look at where have people gone, tend to be radiology, teleradiology, because you can interpret imaging from afar, mental health, and primary care. Like the other extreme is like surgery, telesurgery, which will happen, but requires a bigger setup. So we were the market leader, we got acquired, and the acquirer promptly fucked up the company entirely, didn't allocate funding to the degree that they said they would, were really slow on executing, and that opened up space. So if there's a thesis here, and this may be wrong, maybe self-indulgent, but I want to fund Breakthrough 2.0. Go after the insurers. And look, the first insurer we signed took 2.5 years. It was Blue Shield of California. But when we signed them, they suddenly covered 2 million Californians for Breakthrough. Mentioned now they could just use their insurance benefit and pay the same copay they pay for in-person care. And taking a step back about this thesis, why choose insurers? Because we have a happy problem in mental health of lots of different markets you can go after. You can go segment by condition, depression, anxiety, PTSD, and so on. You can go after different age demographics, millennials versus older folks. You can go after colleges, military, self-insured employers. So the reason we chose large insurers is, let's take Google as an example. I hear a lot of companies in mental health going after self-insured employers. They have about 20,000 employees in the Bay Area. Signing Google probably take between 6, 12 months, maybe longer. When you sign Blue Shield, if it takes 2.5 years, you cover 2 million, right? So you spend 2, 3, 4 times as long and you get 10 to 20 times the member base. So if you have the patience and the funding to go after those larger insurers, it actually makes more sense. So we went after that. But I would say you could find teams that it would make sense to go after military, but you have to build the company around it, right? You probably have to get generals on your board or in your team, deep Rolodex there, really know the VA system inside and out. They should be focused on certain markets.
And let's unpack more. How do insurers think about digital mental health? How should they think about it? What does it solve for them?
Right. So it's very much, it's like a large enterprise sale where you really have to know what the actual success metrics of the large company are. And I think a anti-pattern here is a product and tech heavy team who believes that this is a product driven market. And unfortunately it's not. And that's sad for me to say because I'm a product focused entrepreneur, but it's really sales and marketing driven. Pick first sales in order to get the reimbursement and then marketing to get the patients. And patient acquisition is the hardest part of this market. And you'll see teams say, well, we just get the insurers and they'll market us. Here's an example. We signed Aetna to cover something about 2 million Texans in Texas. And they were supposed to, by contract, put a little icon on all the providers in the Texas Aetna directory that were affiliated with Breakthrough. It took 6 months for them to add that icon. I was like, I could fly down to Texas, find the IT administrator, take them out to dinner, sit down with them and put this icon there faster than this would take. But they don't feel urgency. It's a lot of priorities. So I think you really have to understand what are the possible metrics for these insurers? The most common one is cost reduction. And they won't always admit that up front, but that just directly goes to bottom line. But some of these are regulated to the degree that they can't actually make more than a certain profit cap. So it's not always cost. Sometimes it's improving the provider quality so that they can gain member retention, patient retention. And it's not every patient or every member that they want to retain. They don't want to retain their high flyers that people generate a lot of cost. They'd like to retain healthy people who like that there's this benefit available. Sometimes it's compliance. A cool example here was when we worked with a large payer in California, they were under scrutiny by the state regulator because they were out of compliance with proximity requirements. If you have a certain member on your rolls and there's not a provider within a certain distance, I forget what it was, like 25 miles, then you are out of compliance and at risk of fines and lawsuits. So we went with this payer to the state regulator and said, we want to do online care. Here's the evidence that it works. Will this satisfy the proximity requirements? And the regulator came back and said, yes. So now suddenly we helped them solve a compliance problem. It's one of the reasons I love telemedicine is that it's not just one value prop. It's like 3 to 4 value props, and you can adjust the pitch to the insurer based on what's important. But I think there's a more general question, like how do you learn what's actually important? Because I don't think often you can take at face value what these executives say, and sometimes they don't honestly know. They've been there 10, 20 years. It's sometimes a cushy job. And so this is a threat and an opportunity. The threat is they don't sign because they don't actually know what they want. The opportunity is you set the goalposts. You come in and say, here's how to think about telemedicine. Here's the success metrics you want to set. And you might even be able to set the goalposts a little lower so you can meet them, but not too low so it seems like you're sandbagging. And that's part of the thing we learned. There's one other important aspect, which is how involved do you get in the delivery of care? We wanted to be a ideally pure marketplace. We don't manage the providers. It's just we are connecting them or we're selling white label. And we started with white label and sold a few contracts, but nothing big. And what we learned is the insurers wanted a turnkey solution that combined the technology that was HIPAA compliant, easy to use, and the provider network. What insurers are used to buying is clinics. A clinic that comes to them and says, we want to accept your insurance. We will serve your patients. We would like this rate. There's a negotiation, and that process can be done in 3 to 6 months. We were coming in trying to sell technology, which is a totally different workflow. You come in, you're trying to sell the CTO. You have to go through a HIPAA compliance thing. And at the end of the day, the economics are not as exciting as selling delivery of care. But I didn't start Breakthrough to be the head of a clinic. I wanted to be the head of a technology company. And that's just isn't what the end customer wanted. So after a lot of thinking and research until we said, okay, we are now suddenly effectively a clinic. So we went to the insurers, basically hacking the sales cycle and coming in and saying, not only do we have this tech, we are basically a clinic. We want to serve your patients with our providers. We're just like a clinic, except our providers happen to deliver online care as well. And we now manage the recruitment of providers. We train them. We kick them out if they aren't performing well. And that's what worked. But that's a lot. And tech founders who weren't looking to start a clinic are understandably reticent about that. But I think that's actually what the market is needing.
Right. Is that what Two Chairs is doing?
They're doing it in person. I believe they are working on reimbursement, and I think highly of Alex. It's early for them. I think I would guess that they'll eventually get to an online component. It's an interesting strategy to start with in person because it's a proven model. But if you want to build a venture-backed business, you probably have to eventually go online or do something more like what Omada is doing, where you're not just selling therapy, but a comprehensive package, ideally paid for by some payer that combines, and we can talk about like these 4 things of human involvement, metric tracking tech, content, and community.
Yeah. Are you bearish on sort of the One Medical for X? Must pick a segment and build a One Medical for it? Or do you think that there won't be venture returns unless they have some sort of online?
I think the economics just get a lot better with online, right? You can serve a statewide, nationwide, and eventually a global-wide audience. You reduce your capex on having to have these fancy offices. I do think that One Medical, it has clearly had some measure of success, but I think that the greater margins is going to be in virtual clinics. There might be this hybrid model where you have a clinic, but the bulk of the sessions happen online. And actually, funny enough, an interesting comparable might be where I think food companies are going. Like when there are self-driving cars everywhere and you have cars optimized for pizza delivery, there will be, I think, restaurants that have a small footprint for dining in, but the bulk of their business will be delivery of food. And I think you'll see some that are like warehouses where they're just producing all the food, but you can't actually go in and get a pizza there. Right. And my guess is the economics of that are better.
Yeah. Let's talk about telemedicine for a second. What are the most promising telemedicine companies just broadly in digital health? And what's it going to take for telemedicine to be more mainstream?
So I think for it to go mainstream, unfortunately, the number one driver is going to be reimbursement, which is partly driven by regulation. So the Centers for Medicare and Medicaid, CMS, recently issued this year new CPT codes. CPT codes are what doctors have to use to get reimbursement. That expand use of telehealth. A big restriction there is you still, to my knowledge, have to be in mental health serving a patient who's at a originating site, which is a hospital, some non-home place. And so that greatly limits where you can serve people if they have to go into a hospital. And also there's some restrictions around only going to rural areas. So that's one. Second is consumer education. So let's use Teladoc as an example. Teladoc is public now, over $3 billion. They're going to do $400 million in revenue this year. They have 22 million paid members, but only 2.5 million visits from those members. So you might wonder, how do you have 22 million paid members, but only 2.5 million visits? That's a utilization rate of only 8% of people that are supposedly being paid using the service. Well, so they sold self-insured employers on capacity. They make money just by having the ability to see a provider. And now they're focused on primary care. They do have behavioral mental health services, but the bulk is primary care. So I think an enabler will be the education that that companies like Teladoc and Kaiser are creating, where people become more aware of it. And also the comfort of all the players, both the startups and the buyers, of paying for capacity. Because if you just do it on utilization, if you look at 8% of Teladoc's members using sessions, trying to get a per transaction fee on that, the revenue gets a lot smaller. And you can look at the public docs on the bulk of the revenue comes from this capacity, not the utilization. So when I see startups saying, well, we're going to just earn like $10 or $20 per session, well, if you do the math on how many sessions you need to get to $100 million in revenue, it's a lot.
Right. So let's talk more about regulation. How helpful is it? How hurtful is it? How should startups think about regulation?
Part of this is moot because that regulation is going to exist in the United States, right? But I think it's fair to ask what's helpful and not. You'll hear different views on that. My view is it can be helpful. I would like to see it as light touch as possible because the more the regulation, the more it tends to be rigid and inflexible. I'll give an example here. In California, which tends to be more forward thinking in the use of tech, the doctors used to have to produce in-person, I think it was either faxed or mailed informed consent. You could not have informed consent to be virtual for telemedicine. So someone would have to sign some informed consent paper and then send it in. And like, obviously that's a barrier. The problem is even when everyone can agree that a regulation doesn't make sense, it's hard to get all the parties together that are trying to write laws or update laws in lots of different areas to actually fix one. It is what it is, right? So I think the question is, how do you manage regulation? Do you try and work with regulators or go under the radar? This is an area where I don't think you can pull off an Uber because providers work too hard to gain their licensure. You have to remember it's like over 1,000 hours to gain your license in California. So if you try to be some swashbuckling founder, go to a therapist, psychiatrist and say, well, we're a little vague in this area, but we think it's probably okay. You're not going to get a lot of adoption. You're going to get people who are desperate and not good. So that was one of the early things we found in our research is these therapists were interested, but they did not want to risk their license. And so what's the ramification of that? We did not do any cross-state practice unless the provider was licensed in the state of the patient, because that's where the care is considered to be taking place. So you can't be licensed only in California and serve patients everywhere. What we did help some providers with is getting licensed in as many states as they like, and there are services that actually help with that. You pay some upfront money, and now suddenly you can serve people in lots of places. Eventually, we will get to a national license that will help. The VA actually just passed this, so now as a VA provider, you can see patients anywhere in the country, but that's only within the VA system. So I'm hopeful that CMS is moving the direction of loosening this regulation. But it's certainly not as fast as I would like.
Yeah. And how did you guys bootstrap the marketplace, and how will the Breakthrough 2.0 get providers on board?
So I think this is maybe the number one thing I would look for along with reimbursement is how would you acquire patients? So assuming you want to get reimbursement, it's a triangle, right? Payers, providers, patients. Getting providers is actually the easiest. It's not easy, but you'll find lots of particularly early career providers that want to try this. The average age of psychiatrists in the United States is over 55.
Wow.
So you can try, it makes sense to try and go for the earlier career folks who are more comfortable with technology. You can get the payers. It's obviously, like I mentioned, takes a lot of time, but no one has actually really scaled patient acquisition. Because as we talked about, they aren't as familiar with it. Even if they have coverage, they may not use it that much. So I look for hacks on how you can actually get people to do this. And one that we thought was really interesting was primary care providers and patient assessments. We learned there was a CPT code for assessment on mental health that primary care providers could earn $20 per patient per assessment. So the average primary care office has about 2,000 patients a year. They, per the CPT code, can give a short questionnaire on your mental health, talk to you about it for about 5 minutes, and earn $20. So that's $40,000 in revenue for a primary care provider's office. 1 in 4 people in America have a mental illness. So 500 patients now on that primary care practice are deserving or needing of mental health care. PCPs or insurers are the number 1, number 2 drivers of referrals into mental health providers. So what we wanted to do was partner with these PCP offices and be the recipient of the referrals of those patients who've been identified as having a mental illness. What is the status quo? These PCPs tend to refer all the patients to just 1 or 2 therapists. It's someone they know, someone they dated, they met at medical school. It tends to not be optimized for patients. We want to come and say, we have 1,000 providers in our network, over 300 video introductions. Give that patient just our URL, give them a tablet with the site loaded, and let the patient feel empowered to choose the provider for them, because you're not going to target the provider on insurance or technique or condition, but the patient can do that. And that was a compelling value prop for the PCP. 70% of psychotropics in the country are prescribed by PCPs, but they don't like that. They don't necessarily know the dosaging or the side effects as psychiatrists do. So they would actually rather have mental health specialists do that. And mental health providers know that these referrals can be a big business driver, but they're not going to go in and sell PCP. So that's where there's a value of a breakthrough 2.0 coming in, brokering those relationships. And another benefit if you can do that is you don't have to pay the PCPs anything. It's actually illegal. It's called fee splitting if you pay for a patient referral. But you can solve other problems for them, like handling the compliance thing and also doing coordinated care, where when the session happens on your site, you have the outcome of that filtered back to the PCP in their electronic medical record. So the PCP can be aware of what's going on with their patient.
So we talked about telemedicine. Let's talk about digital therapeutics. What are opportunities or white space there?
So I mentioned, I love the Omada Health program. I see startups that are trying to do just one or two components, like only CBT courses, or only a community. And I'm not convinced that there are VC fundable businesses there. But when you can offer this combination of four things, so let's talk about each. One is content. So I think clearly content around how to manage your depression, your anxiety, someone can be useful, especially if it's well packaged. Second is a live person. It's probably actually the most important. I'm biased on this, but you'll see product folks from the Valley who will say, well, we'll be able to do a lot of behavior change just with content. I'm like, how many people do you know that were able to lose significant weight just from content? How many people use personal trainers? How many people use actually live therapists? Most people, in my opinion, really benefit from that live interaction. People who can customize the course content. And then there's also a proven business model that is larger than everything else that we're gonna talk about in this package of paying someone for their time. It's hard to get people to pay for content they feel that they can Google. They understand that if they're gonna have a human involved, they're gonna have to pay that person for their time if they want quality. The third is metric tracking tech. So a Fitbit to measure your weight loss, for example, with Omada. Here it could be hopefully something that is valid on measuring, like it could be galvanic skin response, which is associated with stress. It could be hopefully something that measures mood accurately. But even I think some of the basic biometrics would be relevant. Like if you're gaining a lot of weight, there's some correlation there with depression. A fourth is community. So AA, I think, has shown that this community of peers is powerful for staying on track. So if you can combine all of this, I think what Omada's shown is you can sell that to at least employers. And I would believe there are other buyers in the order of like $1,000 to $2,000 per patient. And they've already shown some evidence that it works in programs like diabetes. So I would like to see, I think there's Omada Health like opportunity for each of these major mental health conditions.
Right. There's an opportunity to build sort of a dominant brand, mental health, that I can't think of one necessarily. I don't know if the analogy is SoulCycle or Weight Watchers or something else entirely, but
yeah, I think it's a huge opportunity. It's what Breakthrough wanted to build. And I think we were on our way to.
How do you think about self-employed or self-insured employers as a channel?
It's the white whale of digital health startups, even beyond mental health. And I feel mixed on it. So many companies have gone after it. Lantern was the latest, right? I know Alejandro there, and they weren't able to do it.
Why did Lantern fail?
I would defer to Alejandro, but what I hear and what I read outside is they couldn't sign enough self-insured employers to make that work. And what Alejandro said publicly is what I've talked about here, that getting the insurers is the big game, and it's hard. And if you don't have that expertise in the founding team, in your DNA, it's hard to bolt on later. So now when I see pitches from mental health startups, one of my first questions is, do you have a sales executive with a deep experience? So I think the major reason we were able to sign insurers, this is a question I get asked all the time, and what I say is, we had a secret weapon, and his name was Julian Cohen. He was my co-founder, whose entire 30-year career was as a mental health executive. He was the CEO of Cigna Behavioral, the mental health division, the chief marketing officer of Optum Health, the mental health division of United Health. He was the president of the Institute of Psychiatry at Northwestern. He has a master's and bachelor's in social work and a master's in public health. So he had a deep Rolodex. And that really matters. Like when he signed on, within I think 2 weeks, he had a half dozen executives from Optum in a room listening to me, the 35-year-old fresh-faced CEO, saying, please give us 2 million of your mental health patients. And we learned over time it's really better for him to lead that conversation than me. But it was evidence that this is not a product-focused market. It's a sales, relationship, marketing-driven market. And of course, you have to get the sale in order to have the opportunity to do the marketing. So when I look at a team, I really want to see both of those expertise. And then ideally a third expertise of a doctor, a clinician who understands how care should be best delivered if there's going to be any management of providers or content.
Right. So we talk about telemedicine, we talk about digital therapeutics. You mentioned you're dubious on AI chatbots.
If anybody who's used them, I just don't think they're quite there in terms of the sophistication where it feels human-like. I do believe there will be a tipping point where it'll be like Eliza 2.0, where you look forward to talking to your AI chatbot. So the big question here is, when will that happen? What's the first company that will deliver an AI where people are like, I like this as much as talking to my human therapist? And I think that's actually like a data and algorithm technology sophistication question. Obviously, like having someone like Andrew is a good vote of confidence, but you can actually just look at the data there, right? Of how often do people engage with it? I do believe that eventually I would be able to customize and feel human enough. So market timing is the big issue there.
We're seeing with at-home diagnostics or things that are trying to replace the pharmacy in some way. And I'm curious how wide it extends and sort of where companies like Nurx go. Like you have birth control on demand, you have PrEP on demand, but it's interesting to follow just that whole sort of broader space, one D2C to like things like PillPack, pharmacy, and see what can actually win versus what is Amazon just gonna take.
Right. When I look at all of these D2C digital health companies, I think, why is it D2C? Is it because consumers actually want that? Or is it because it's easier for the founders than going after the insurers? So let's take an example of something like Casper, selling beds direct to consumers. Tesla, selling cars direct to consumers. I think consumers want that because it lowers costs. It's easier than going through a dealership. Digital health, it raises costs to go through a consumer. I think a lot of people, and this is proven in the data, 90% of spending paid for by a payer. So I think in many cases, the entrepreneurs are going for consumer because they don't want to go through the hell of a 2.5-year sales cycle. Understandable. But we as investors have to say, what is really the demand? And I think there are self-pay markets that are available, but they're smaller, much smaller than the insured model. So I think the big win, and here's Teladoc as an example. Teladoc works with insurers and employers, and they've built the biggest player in the telemed space. By the way, they've been around for 16 years. They went through a painful recapitalization of the company. So this is an area where experience probably helps, but I would believe that there could be a fast follower that takes the best practices. But this is a painful market. It's super hard. And I think that's also market timing is hugely important because there will probably be some step function up in utilization when some of these regulations are loosened. And there'll be a gradual acceptance of telemed when people's insurance like Kaiser says, hey, we now do video visits and teach people how to do it. Also devices, right? So now we have these supercomputers with cameras that we're carrying around in our phones. And I'm optimistic that things like 5G, internet access, will make it easier to have a good telehealth consultation. The audio is actually more important than the video. If you've ever had a video conference where the video sucked, but the audio is okay, you can have a conversation. But if the audio is bad, it doesn't matter how good the pixels are, you can't have a good conversation.
What are other examples of unicorns in the digital mental health space? Are there any?
No. Depends on how you define mental health. So I think an interesting comparable is Headspace, right? I don't know that they're a unicorn yet, but they're reportedly doing quite well. So Headspace is a meditation app, meditation content. But meditation is mainly a solitary exercise, right? And so there, I think delivering content that people pay on a membership basis makes sense. Therapy is, to date, an interactive experience. You have to pay for someone's time. Now, yes, you can do CBT, but again, how many people have personal trainers versus just like go to the internet and actually pay for content that they can otherwise get for free, like watching YouTube? Like, I would believe a CPT app could get traction, but is there a business there? Well, I've seen some say, well, we'll charge for sending referrals to therapists. And then I say, how many therapists have you talked to who are willing to pay for leads? A, in a lot of areas, it's probably going to be illegal. It's going to be fee splitting. B, the average salary for a therapist in the United States, unless I checked, is about $50,000. It's higher for psychologists and even higher for psychiatrists. but they are not used to paying for leads. And what lead generation services do is they do membership flat fee services. So Psych Today, for example, Psychology Today is, I think, the largest directory of providers, and providers pay a small monthly fee for that. And even then they complain about it. It's just not behavior they're used to. So I'm skeptical that any app that wants to make money through lead generation is actually going to reach VC returns.
Right. And let's zoom out even broader from digital mental health into just digital health broadly. What topics are you most excited about from an investing perspective, / where are you most eager for entrepreneurs to innovate or build?
I'd love to see improvements in diagnostics. I think a lot of people don't actually know what's going on with them. And if we can ground that in data and better tests, I think it was one of the exciting things about Theranos, right? Before it blew up, that we'd be able to more affordably figure out through blood what is going on. Like, I'd love to see continuous blood monitoring startups. Something like 70% of meaningful biomarkers I've read in the body are in the blood. So I know it's kind of a poison market now because of Theranos, but I would believe there will be a company that succeeds there. It requires some innovation in microfluidics, but hopefully it'll happen. I think AI applied to medical imaging interpretation is pretty exciting. Obviously, with deep learning, we're seeing some performance of AI in interpreting imaging that's better than humans. I actually think also some of the workflow that happens in medicine could be improved. Like, so my girlfriend is a GI doctor, and she spends a lot of time writing pathology notes and trying to capture some of the knowledge that happened in the consult. It seems like an area where you should be able to have AI that's good at transcribing. It's HIPAA compliant. It's easily stored in the electronic medical record. I don't know that there's a big company there. You might have to use the data in some way. And another that I'm actually really excited about is clinical trials. It's a huge business. These CROs that manage clinical trials are multi-billion-dollar companies, and nobody's heard of them. Quintiles, Parexel, Icon, Charles River. So I would love to see virtual clinical trials where you can enroll and contribute data to a trial remotely. I'd also like to see a consumer brand around that. So I think an Uber for clinical trials, if you can put it that way, could be a huge business. Whether it's just the finding that happens or the actual contribution of data as well.
You said you had some controversial thoughts. I'm not sure if we got them out. Maybe we did.
I do see some companies that are trying to work with non-therapists, so listeners.
Right. What do you think about that?
I'm bearish. I don't. And it's not because I think a license necessarily makes you a great therapist. I would believe, and maybe some of my therapist friends will yell at me for this, that you could be a potentially great therapist without having to go through all the licensure work. It's just hard to make the business model work then. Right. And it probably exposes you and the listener to liability. Certainly you can't prescribe medication without licensure. And there'll be entrepreneurs who will say, well, if we don't call it therapy, it's not therapy. That's probably not how regulators will look at it. They don't tend to abdicate their responsibility. They tend to look at something and say, if it looks and sounds like therapy, it's therapy. Maybe I'll be proved wrong, but to the point, it's the business model. I don't think people are willing to spend as much for non-licensed providers, and there are already actually free alternatives like hotlines that you can access. Again, could be wrong.
Yeah, the counter is that, if you pay maybe half the cost, maybe a third of the cost, and you take out people who do customer support who get like $8 an hour, $10 an hour, and instead of listening to angry people, talk about why they didn't get their product shipped, they're now listening to people talk about their problems, which would be a lot more interesting to them. Could you create a marketplace where the unit economics could work out, where they're paying significantly more than the company is paying these customer support reps to listen in?
Well, I think it's telling that though plenty of companies have tried, none has reached large scale. And I think that's evidence that this skill set of listening and being familiar with the knowledge in personal growth that a therapist gains, and just the skills of being gentle enough to hear someone out, but being firm when it's necessary, it actually has real monetary value. And the people who are willing to do it for $10 to $20, $15 an hour probably don't have those skills. I mean, you'll find exceptions, and it's understandable. There is arbitrage here, right? Where there are plenty of people who don't want to go through the stringent licensure requirements. But I think the people who are going to be good at it will, in general, and they'll earn the financial upside. Not that there's a huge financial upside to it. But I think this is an area where I could well be wrong. And then the question is, what is missing? What is missing from all the previous attempts to do this? And maybe it's provider, we'll call provider here, quality, that you really have to screen and train for those people. Maybe it is a patient acquisition. It certainly is at least a patient acquisition challenge. How do you acquire people? And there's a benefit if you're not working with insurance, you can target everyone. Whereas with Breakthrough, one thing we struggled with is how do you market to people who have a specific insurer? That's not a vector that you can target on Google AdWords. It's not a vector you can target on Facebook. And until you accept every kind of insurance, or many of them, you have to find ways. So you maybe target keywords like Blue Shield therapist, but there's actually not a lot of keyword here. And it underscores that patient acquisition is hard because a lot of people aren't yet searching for online care. And it's effectively a double sale. I have to convince you to not only try therapy, pretty hard, and to try it online. And I can talk about the many value props of telemedicine, but still hard. And people have questions like, well, is it actually secure? Is the FBI or the CIA listening in? Is somebody else going to learn about this because it's digital instead of on paper? I mean, Watergate was literally, I don't know how many people know this, but Watergate was around mental health records, right? The president was brought down because of the break into a provider's office. So I think the companies that really if they crack patient acquisition, they can build a big business.
Cool. I want to close by giving you an opportunity to talk a little bit about VentureKit. You have some amazing videos, amazing content out there. Why don't you talk a minute or so about what you're trying to do with VentureKit and what people can learn online from it?
VentureKit is aiming to be the best educational resource for founders on how to do hard things in startups. And it's just early stage, but it comes out of my frustration as a founder of not seeing good guides on how to get things like hiring and managing and building a financial model and building a pitch deck, interviewing. What I saw that I and other founders were doing is pinging each other about how to do these things. And if you Google for it, you see stuff like founder stories, like Tim Ferriss will interview a lot of founders, and that's good for entertainment. Yeah. But like I watched a 2.5-hour interview with him and Joe Gebbia from Airbnb, very entertaining, zero takeaway for me on how to be a better founder. There'll be motivational speakers, like kind of targeting entrepreneurs and wantrepreneurs about how to do startups. But at the end of the day, the great founders are trying to improve the craft of what they do, and there's just not great essential source on how to do that. And so I want to get into the deep best practices of how to do these hard things, particularly around interpersonal skills. And that's where I think video shines. So I started with some articles. That's pretty crowded because part of my, like, I really believe in the mission, but I also, as a new investor, want to meet great founders and I want to show the kind of value that I can provide. And so it's pretty crowded in doing that in articles. I did some podcasts, but I saw really, I think the white space for investors like us, and for this content is video. And YouTube is the second largest search engine in the world. So I've just started out producing some videos. It's really just me talking at the camera right now, which is me getting my feet wet. But where I want to go is showing domain experts doing what they do. Because if you haven't been around a top 1% product manager, interviewer, founder, how do you know what doing these hard things well looks like? So I'm going to get an expert interviewer in the room and show them interviewing someone and talk about it. If you ever seen the series from the 80s, Blind Date, it's where you watch these two people go on a blind date and then you see these thought bubbles of what they're thinking, supposedly. And you'll hear expert, like there was an expert dating coach who would talk about what he's observing. I think you can do that kind of jokey kind of model where you'd have the expert performing a skill, and then you get to talk to them afterward and say, "Here, what were you thinking? What body language did you notice when you were probing this area that the other person seemed to be cagey about? What signaled to you that that's where you should probe? What did you like about this candidate? What did you not like about this candidate?" And I think just the story format doesn't show how to do these skills as well as actually showing these skills done.
Awesome. And VentureKit.co?
VentureKit.com.
Perfect. Mark, thank you so much for coming on the podcast. I'm so happy to have you as Village Global Network leader.
Thank you.
If you're an early stage entrepreneur, we'd love to hear from you. Please hit us up at villageglobal.vc/network catalyst.